Thank you, moderators. I'd also like to take the time to thank the organizers of this symposium for inviting me here today, and greetings from Philadelphia and Drexel. So I have no conflicts to disclose today. And I must admit, about 6 months ago, when Dr. Sukjin Lee asked me to do this talk, I was sort of deciding, wow, you know, what can I talk about that's actually an update in heart failure treatment? Because when you're doing it on a day-to-day basis, it's sometimes hard to see change coming. But if you go to the clinicaltrials.gov website, I was surprised to see that there are actually 1,400 trials worldwide right now in heart failure that are currently enrolling. And of those, about 238 are actually in phase 3 studies. So there's a lot happening in heart failure. And of those trials, we have pharmacologic, device therapy, and also stem cell studies that are ongoing. But what I'm going to talk about is the bread and butter of heart failure and what's actually clinically available for us now in terms of treating patients. So the first question you always ask yourself, is there anything new happening in neurohormonal blockade? And the answer to that is yes. So actually just in the past 2 weeks, we've had new guidelines published by the European Society of Cardiology, which actually now lists the angiotensin receptor neprilysin inhibitor as a class 1 indication for treatment of chronic heart failure with reduced ejection fraction, as well as the sinus node inhibitor of Aberdeen. So I'm going to spend some time going through the clinical studies that led to these changes in our recommendations. Oops, let me go back. Okay. So as you know, in heart failure with reduced ejection fraction, there is activation of the natriuretic peptide system, which leads to increased AMP and BNP levels, which is actually beneficial for heart failure reduced ejection fraction. And on the flip side, there's also activation of the renin-angiotensin-aldosterone system, which is, of course, detrimental to heart failure in the long term. So our classic therapies have always looked at using ACE inhibitors and ARBs to block the detrimental effects of angiotensin II, but more recently, actually in the past month or in April, there was a study finally published on the use of aliskiren, which is a direct renin inhibitor in the treatment of chronic heart failure. So I'm going to go through that. And then in 2014, there was a publication of the Paradigm HF trial, which led to the changes in guidelines that we've just had in May. So in terms of aliskiren, so aliskiren is a direct renin inhibitor, and in the atmosphere trial, they compared the use of aliskiren versus enalapril, and there was also a third group, which was an enalapril plus aliskiren, so combination therapy. And they looked at patients who had predominantly class 2 symptoms, that they had to be symptomatic on standard therapy. So the majority of these patients were actually class 2. The average age was 63. It was predominantly a male cohort, and they were recruited from countries around the world. The patients were predominantly ischemic, and the ejection fraction was 28%. And again, about 64% of these patients were class 2 at the time of enrollment. Also, in terms of baseline characteristics of these patients, about 60% were hospitalized for heart failure the year prior to enrollment. And it was a very well-treated group, so you had to be on an ACE inhibitor to be enrolled. And about 92% of the patients were also on beta blockers. So they were on modern treatment for heart failure And so what did they find in this particular trial? Well, it showed that there was actually no benefit for combination therapy, which is enalapril plus aliskiren versus enalapril, and the same with aliskiren versus enalapril. So this trial, which was just published, showed that there's really no benefit in terms of the primary composite endpoint of cardiovascular death or hospitalization, first hospitalization for heart failure. If you looked at just cardiovascular deaths alone, there was also no benefit with aliskiren. Same thing can be said for hospitalization or death from any cause. What about potential side effects with aliskiren? Well, what they found is that patients who were on combination treatment, so that's aliskiren plus enalapril, there was more symptomatic hypotension. And they also found more renal insufficiency. So what the authors of this study took from that is that, yes, RAS was blocked to a greater degree with combination therapy, which is evidenced by the hypotension and renal impairment, but at the same time, you got no additional clinical benefit by blocking at the level of renin. Also, which was interesting, is that there was still cough in all 3 groups, even in the direct renin inhibitor, but there was no difference in terms of renin inhibitor versus ACE inhibitor for cough. So their conclusion was there's absolutely no additional benefit for adding allosterin in terms of reducing mortality or hospitalization for patients with chronic heart failure, and you actually gain more adverse events by blocking the greater blockade of the RAS system. So the next trial that I want to present is the Paradigm HF study, which was published back in 2014. And this study looked at the use of an angiotensin receptor blocker and a neprilysin inhibitor versus enalapril. So the thought is here is that you would block angiotensin II effects at the receptor level and at the same time leverage the beneficial effects of natriuretic peptides by decreasing their metabolism with the neprilysin inhibitor. So this study population, again, patients were predominantly in their early 60s. It was 80% male. Patients were recruited from around the world. And to get into the trial, you didn't have to have a hospitalization, but you had to have an elevated BNP level and heart failure symptoms. And so the mean BNP level in this trial was 255. It's predominantly class 2 patients at 72%. And again, about 60% of these patients had been hospitalized in the year prior to enrollment. So what they found in this study, which actually led to the change in our guidelines, when they looked at the primary endpoint, which was cardiovascular death or hospitalization, first hospitalization for heart failure, they found a benefit with LCCZ, that's the ARB NEP inhibitor, over enalapril. The trade name for, or the generic name for that is, which is hard for me to say, succepitril and valsartan. But when you look at the combined endpoint, there was a benefit. When you look at death from cardiovascular causes, there was also a benefit conferred from LCZ 696. The same can be said for hospitalization for heart failure and death from any cause. So this particular medication was superior to enalapril in basically all of the endpoints, and that's what led to the change in the guidelines. When you go to the adverse event profile, so this drug was actually the benefits of neprilysin inhibitors was known really back 10, 15 years ago, and the first iteration of this particular use of this drug was to combine it with an ACE inhibitor. But that drug was never made it to market because of the increased risk of angioedema and other side effects. So the hope was that with combining it with an ARB that you would get away from having those side effects. So what they found in terms of the adverse risk profile is that patients who received the ARB NEP inhibitor were more likely to have symptomatic hypotension. But when you looked at parameters like renal function or elevation in serum potassium, actually enalapril had higher adverse events in the patients who got the NEP inhibitor. When you looked at angioedema, patients still got angioedema on this drug, but it was no different than when compared to enalapril alone. So the safety profile of this particular medication is actually quite good. The one thing that I've actually noticed in clinical practice is that the hypotension is real, so you have to start really, even if your person is on a maximum dose of an ACE inhibitor, I still start at the lowest dose when I'm beginning because of that, and also drop the diuretic dose when you begin to start it. So what they concluded from this study is that angiotensin receptor neprilysin inhibition is superior to ACE inhibition alone in reducing the risk of death or hospitalization for heart failure. So what about in the realm of non-hormonal neurohormonal blockade? So the next trial, this is actually the SHIFT study, which was published in the Lancet back in 2010. It looked at the use of the drug Aberdeen, which is a sinus node inhibitor, in treatment for patients with systolic heart failure. In the US, the drug wasn't actually available until 2015, and so now it's finally made it to the guidelines. But this data is actually from 2010. So what they did in this study, they actually wound up randomizing about 6,500 patients to Aberdeen or placebo. And the hypothesis is that for patients who are already on maximal tolerated beta blocker, if you decrease the heart rate even more with the addition of Aberdeen, that you'll have a clinical benefit. So that was the hypothesis for this study. Can you block the heart rate even more with Aberdeen and get a clinical benefit? So they randomized 6,500 patients in this particular trial. And if you look at the baseline characteristics, the average age was 60. Again, predominantly male. And the heart rate going into the trial, resting heart rate for these patients who, again, are on background beta blocker therapy was 80. They had a reasonable systolic blood pressure of about 120, EF 29%, reasonable renal function. And this had more class 3 patients. So 50% of the patients enrolled in this trial were NYHA class 3. So remember, this was added on top of a beta blocker with the goal to drop the heart rate. So if you look at the concomitant drug therapy of patients who were in this trial, 89%, 90% of the placebo group were already on a beta blocker. And in terms of ACE and ARB, 95% of the patients were on RAS blockers. So again, very well-treated group of patients who still had symptomatic heart failure. These patients had an average diagnosis of heart failure for about 3.5 years. Predominantly ischemics, and they had the other host of comorbidities that we're all quite familiar with in this group of patients. So for those who were on beta blocker at the beginning of the study, again, about 90% of the patients, they were all on pretty good doses of their medications, even though about 1/4 were at what we would call target dose. So the dose is recommended in the clinical guidelines, and about 50% or 56% were on over 50% of the target dose recommended in clinical from the guidelines. And the reasons that people were not able to be on the maximum tolerated dose of their beta blocker were the common things that we run into all the time with beta blockade, hypotension, fatigue, dyspnea, dizziness, bradycardia. So these people couldn't be maxed out for clinical reasons, but they were still on pretty reasonable doses of beta blockers in entry to the trial. Pin the wrong button. So what about the patients who were not on a beta blocker at the time of enrollment? So beta blocker intolerant patients, and that turned out to be about 10% of the patients. And the beta blocker intolerant patients was due to basically lung disease, so COPD or asthma, hypotension, bradycardia. So even though some patients had bradycardia with the beta blocker, you could still be enrolled in this study. Just to prove that the drug actually does decrease your sinus rate, in the placebo group, the resting heart rate was 75 at entry to the study and remained steady at that. And for the Aberdeen group or the treated group, the heart rate dropped another 10 points to about 65. So this is Aberdeen on top of beta blocker therapy. So what did they find in this particular trial? Hopefully you guys can see this. In the first panel, it actually shows the combined composite endpoint, which is cardiovascular death or hospitalization for heart failure. And so here's the placebo group here in red and the Aberdeen group in blue. So there was a statistically significant benefit from the use of Aberdeen with regards to the composite endpoint. And this was all basically driven by heart failure hospitalization, so, which is depicted in this particular screen. If you go down to just cardiovascular death, there was really no change. So the composite was really based on decrease in heart failure hospitalizations. So what about adverse events in this particular trial? What you see in this slide are adverse event, or this part of the slide are adverse events that were noted, and then over here you have adverse events which actually led to withdrawal of the drug. And so it actually was only about 1% of bradycardia that would actually cause patients to be withdrawn from the study. So that was nice to see. So in terms of adverse events, Aberdeen was more likely to cause bradycardia than placebo, which makes sense. And the other thing that Aberdeen had is this side effect called phosphonis, which is actually seeing bright lights. And that happened in about 3% of the patients. And it goes away when you stop the drug. So with those two studies, the new guidelines from the European Society of Cardiology recommend that you can add a combination ARB neprilysin inhibitor for patients with reduced ejection fraction who remain symptomatic despite optimal medical treatment. So the trick with this class 1 indication is that they remain symptomatic despite optimal medical treatment. So what they're getting at is that right now it's not a first-line drug. Now there's going to be a study underway to see if in de novo heart failure patients, if there's a benefit with starting this drug up front. But right now the European recommendations are if you have symptomatic heart failure on standard treatment. In terms of the use of Aberdeen or the sinus node inhibitor, it's now indicated for patients with symptomatic heart failure, EF of less than 35%, heart rate of greater than 70, on beta blockers and ACE inhibitors who also remain symptomatic. So that's going to be the niche for that group of patients. So what about predicting outcomes for heart failure with preserved ejection fraction? So again, if you look at the last set of European guidelines, they go through the things which we all think about in terms of predicting prognosis for patients with heart failure. That's severity of their heart failure symptoms, their clinical status, markers of remodeling on imaging studies, and then biomarkers. And so in terms of biomarkers, it turns out that for what's available to us clinically, really the most important things are markers that show activation of the RAS system, which are basically a low sodium or high BNP levels are still the things that we have at our disposal from a clinical point of view. Other biomarkers are just evidence of worsening end organ function, such as renal dysfunction. In terms of the BNP story or the pro-BNP study, this comes from the VALHEF trial, which was published many years ago, but this particular analysis was published in 2013. And it basically shows that for patients who started in the VALHEF trial, who had a high BNP and who their levels remain high during the course of the trial, they had a worse prognosis when compared to patients who started high and their pro-BNP levels dropped. So this led to the question of, well, can we use pro-BNP levels to guide treatment? So in other words, can we force the BNP levels down and also improve prognosis? And so that trial is actually called the GUIDED study, which is an NIH-sponsored trial. And in this trial, patients are randomized to either standard therapy, which they just call about symptoms, and their medications are adjusted based on clinical parameters, versus adjusting their medications or therapy based on strictly their BNP level. And so that study hasn't finished yet, but we'll see if just using the marker of BNP in addition to clinical correlates is actually useful in decreasing hospitalization, improving outcomes in heart failure patients. So what about device monitoring? So we know that BNP levels and low sodiums, et cetera, will predict worse prognosis over time. But what about for acutely decompensated heart failure? Is there a way we can actually predict who's going to have a decompensation and hopefully in real time and hopefully prevent them from being hospitalized or deteriorating? So we know from Wolf et al. Back from 2007, he looked at the standard parameters that we use to predict acute decompensation. And it's the typical things that we do every day. We know that symptoms of shortness of breath and edema improve about a week or two before patients are hospitalized, as well as weight gain. So that's really our standard mantra in clinical heart failure treatment. Please weigh yourself every day. Please call us if your weight changes. Please call us with symptoms. And these changes or perturbations occur about 1 to 2 weeks before patients have a full-blown decompensation. The other thing they learned is that intrathoracic impedance also decreases about 2 weeks before patients experience a decompensation. The same with heart rate variability. And then hemodynamics change about a week before patients actually end up with a decompensation. So the thought is, can we do better with instead of just clinical reporting, with getting information from various devices to tell us who is going to decompensate before we'll call them before they call us? This is just to show you the power of having your patients do daily weights. So again, this just shows that for patients who don't decompensate, their weight stays the same throughout the course. For those who wind up getting admitted, their weight increases. So the big challenge in heart failure management is actually getting patients to call you with weight gain and with symptoms. And it's a very easy way to figure out who's going the wrong way. In terms of intrathoracic impedance, so this is a measure of impedance that comes that you can get from a pacemaker tip or an RV lead, where they measure the impedance across the lead from the can down to the RV tip. And they find that as you retain fluid, the impedance decreases. And okay, so that's fine. There's more water, there's more fluid in the chest, so the impedance goes down. But they also show that your impedance changes actually correlate with change in filling pressures or wedge pressure. And so that's demonstrated in this particular graph, which shows that as the impedance falls, the wedge pressure increases in a very nice correlation. So the question is, can this be used clinically to predict who is going to have a decompensation? Whoops, I can't go back. Okay, so that brings up the DOT trial, which was published back in 2011. And so what they did was use The device that measures intrathoracic impedance is called the Optival. So what they did in this particular study was measure patients' impedance every day, and there was actually a device alert. So when the impedance began to fall, the treating physician would know this and the patient would know this. So the patient would actually hear an alert. So there were two ways that if a patient was starting to have their impedance drop, that they were to notify the clinical team to make treatment adjustments. So that was a device alert group, and then there were a group of patients who were just monitored with standard intervention. And what they wanted to find out from this study is whether this device could pick up a decline in impedance, make clinical adjustments, and whether or not that would decrease heart failure hospitalizations. So what they found, if you look in this particular chart, is that the patients in the control arm, and this is patients who had the device turned on that beeped when they were in trouble and was supposed to notify them and their treating team, and they found out that the patients who had the alert on actually had more interventions and more hospitalizations than the patients who did not. So in this case, knowing the impedance ahead of time did not prevent hospitalizations or decompensations. So then the next thing to come along was something called the Chronicle device, and the trial was called the Compass HF trial. And what they did is with an RV sensor, they were able to estimate what the PA diastolic pressure is, which is what you see here. And so again, you got continuous readouts all day, and patients were to download at night, or upload, I'm sorry, at night their pressures. And the clinical team could see this and make adjustments based on the pressures and not only clinical symptoms. And so that was the Compass HF trial. And again, what they found, just like with the Optival study, is even though the number of events, which is shown in black for the Chronicle patients, was lower, it didn't reach statistical significance. So again, knowing the estimated PAD in these patients did not lead to fewer clinical events. So what we can conclude from those two studies is that even though intrathoracic impedance correlates with wedge pressure, and the Chronicle device could actually give you a very good estimate of the PA end diastolic pressure, knowing that information and using it clinically over the phone did not decrease hospital admissions when compared to standard care. So we also have a new device which directly measures PA pressures, and I'll stop there and keep you hanging because Dr. Ledley will talk to you about the results of that particular trial. Kamsa Hamida. Thank you.